a perfect segue to our next session, which is going to be on mental health. And I don't know about you guys, but I need some help in this area after this last year. So it's my pleasure to introduce everyone to Dr. Rona Hu, who's a Stanford professor of psychiatry, who's going to lead this session. Please join me in welcoming her.
Thank you.
Thanks. Thank you so much, Dr. Singh. And I should also point out that Dr. Singh was personally responsible for saving my 90-year-old father from COVID and making it possible to have the emergency use authorization for the antibody. And then a special shout out to Dr. Dale Hu from the vaccine section, who is my lifelong companion in life. He's my brother. It's such an honor to be presenting the mental health section for the Stanford Center for Asian Health Research and Education International COVID Conference. Last year's conference did not have a mental health section because at first glance, a fatal contagious respiratory virus did not appear to have direct psychiatric implications, but the past year has shown us all the importance of mental health. There is no health without mental health. And we'll talk today about some of the profound effects COVID has had on all of us, and especially on vulnerable populations. I'm Dr. Rona Hu. I'm the winner of the 2021 Cant Do Sue Award from the APA, the American Psychiatric Association. But I'll be talking to you today about not just Asian mental health, but mental health for everyone. I'm Associate Dean of Academic Affairs at Stanford University School of Medicine, and I can tell you that the helpers have needed help. There are medical workers who've contracted COVID, and there are a larger percentage who have struggled with burnout during this overwhelming crisis. I'm also a clinical professor in the Department of Psychiatry, where I founded the SMART Clinic, Stanford Mental Health for Asians Research and Treatment. And I've been taking care of patients throughout this pandemic, both on Zoom in clinic, but also live in person at Stanford Hospital, where I was medical director for 20 years. So I can tell you firsthand about the pandemic's effect on people who already had psychiatric conditions as they struggled to get access to psychiatric care. Imagine having depression, anxiety, paranoia, or cognitive problems, and then navigating this confusing new world of the pandemic, while also being told by insurance companies and employers, families and friends, and society that their problems were all in their head. Well, newsflash, the head is part of the body. And our bodies can't function without our minds, and as the rest of us soon found out. The bright spots to this pandemic are the lessons that we've learned and our paying attention to things that we've ignored and helping the people who need help. Our speakers today will present brief snapshots from what we've learned this year. And when I say brief, I'm going to beg for forgiveness up front as moderator for adhering to a tight schedule of 5 minutes each, with questions at the very end when everyone's already spoken. Everyone gets a 2-minute warning. And then 1 minute. So I'll signal with my phone and with my hands, so no one gets shortchanged, okay? Because we have this great panel of knowledgeable, internationally acclaimed speakers. First up is Dr. Stephen Murphy Shigematsu talking about self-care for all of us, coming alive through 3 vital connections. After that will be Dr. Christine Yu Mutier, Medical Director of the American Foundation for Suicide Prevention. And she'll be talking about suicide prevention, threats, and opportunities during the COVID-19 pandemic. Stanford child psychiatrist Dr. Shashank Joshi will talk about mental health and well-being in youth during COVID, and Washington Post reporter Marian Liu will talk about how the pandemic made everything worse for the Asian American community. Finally, Stanford psychologist Dr. Helen Sue will talk about the double pandemic, crisis response, research, and postvention. And then we'll open it up to questions and answers for the whole panel. Thank you, all of you. And I understand that Dr. Murphy Shigematsu likes being addressed as sensei. So sensei, are you ready?
はい、ありがとうございます。
ありがとう。
こんにちは、重松です。今日は雷みたいな話を5分でやってもらいたいと言われたんですけれども、私はとても早い話ができないので、ちょっとゆっくり話したいと思ってよろしくお願いいたします。I was asked to give a lightning talk, but I'm starting off slowly and in a language that many of you may not understand because I want to induce a sense of vulnerability in which we're disoriented, a little bit unsure of what's going on, and have to focus our attention and question our assumptions and expectations. In my clinical work, I often encounter people who are feeling this sense of vulnerability. It's a moment of danger, but also of opportunity. Experiencing vulnerability helps them to feel alive. And in this state, they're especially open to new discoveries, to revelations that have the power of transforming them. We're all now in a state of vulnerability, a mass vulnerability in which our worlds have been turned upside down and torn apart. It's not what we expected to happen in 2020 and 21. We're wondering how to find balance and stability. And it's this vulnerability that there's the possibility of beginner's mind, seeing things in a new and refreshing way, seeing possibilities, sensing connections to ourselves and others, and the mystery of life. Vulnerability also brings the possibility of what in Japanese is called ichigo ichie, the awareness that each moment, even the most mundane moment, is a once in a lifetime opportunity to be treasured. I'm fortunate to work with diverse people, especially with youth, and many are telling me that through their struggles, they're being transformed in these times. The volatile, uncertain, complex, ambiguous world is deeply affecting them. Their solitude has brought insight and internal growth. Their confrontation with mortality, imperfection, impermanence has brought wisdom to their young lives. And as they emerge back into the world, they tell me that they can't return to being the person who they were, or thought they were, or others thought they were. And they tell me that they need to come alive through three vital connections. One is the connection to a self, an authentic self, a true self, not the self they had constructed based on false beliefs, others' beliefs, or their own misguided values. Their solitude has taught them to be more able to be alone and to trust that they'll be all right. They're learning humility to balance their egos. They want to know themselves, who they truly are, and to accept that and to do their best with what they're given. They want to care and be responsible for themselves. Another connection they long for is with others. The pandemic has taught them how interconnected we all are. Their solitude has also taught them how much they need others, bonds, community, shared spaces. The violence they witness shows them how much we need solidarity. And they feel appreciation for friends, family, ancestors, and gratitude for what they owe to an infinite number of people for their very existence and continued growth. They want to walk together and help one another to rise after falling, valuing service and responsibility to others. And they tell me that they need connection beyond the human world to one of spirit, or nature, God, the universe. The pandemic has taught them that no matter how smart they are, ultimately it's beyond our human control. They know that they need to let go of the need to master everything and surrender to the mystery, the wonder and the awe of this world. And they tell me that the way I can help is to experience vulnerability too, to bring beginner's mind, ichigo ichie, and the humility into our encounters, to be human and help each other to come alive by truly seeing, listening, and caring for one another. Thank you for listening.
Thank you so much, Sensei. You've truly earned that
You
title.
don't need to call me Sensei. The students do.
And in this way, we're all students of you.
Yes.
We'll have an opportunity to ask Dr. Murphy Shigematsu more questions at the end. But in the interest of time, moving now to Dr. Christine Yu Mutier about suicide prevention and COVID-19.
Thank you so much, Rona. And it's a pleasure to join this really incredible group of people presenting on this important topic during this time, because we're all having our lives turned upside down in various ways and at the same time trying to help others through it. So I'll be focusing on suicide prevention and really what we know from the data about what has represented significant threats to suicide risk in the population globally during COVID-19, the data that we know about what is happening with suicide rates beyond just distress and ideation, and then talking about opportunities for prevention. Go ahead, next slide. So we all are keenly aware of the many data points we have, and actually can get sort of overwhelmed with a sense of how prevalent and how extreme the levels of depression, anxiety symptoms, not necessarily clinically diagnosable experiences, substance use, and suicidal thoughts. At the beginning of the pandemic, it was 1 in 4 young adults were reporting suicidal thoughts, which is a significant rise from baseline. And these days, the CDC Household Pulse Survey keeps us in tune with those rates as well, and they have remained high actually throughout. It actually breaks it down by age groups and by race ethnicity. So that's interesting to check out if anyone cares to do that. It's the bottom image. Next slide. And go ahead, next slide. Great. So in an invited paper for JAMA Psychiatry, I tried to outline what we could glean from the research about the links between the impacts of the COVID-19 pandemic and what we know. There is some data to say that these could press upon suicide risk factors in the wrong direction, in a negative way during the pandemic, and broke it down into these various buckets where not only are there significant potential threats to suicide risk, but where we have to look at the practical community, policy, clinical, and community-based solutions that have to be prioritized during this time in order to protect against those risks of increased suicide rates during this time. Next slide. Now, one thing to be aware of is that just because the population is experiencing tremendous distress and even suicidal thoughts does not mean that suicide is an inevitable outcome. And that's one thing that we've been very keen to work with media on, shaping a message that is proactive and positive and actually helps contribute to prevention, rather than an unintentional message that might have actually created a natural sort of dialogue that would lead the American population or global population to believe that suicide would be a sort of natural or expected outcome during this period of extreme distress for many populations. Because number one, we know that even when distress is high, but when help seeking is high and when sense of connectivity is high, that suicide prevention efforts can actually prevail. So we've been very busy at work with a number of partners and doing media engagements along those lines, and really trying to emphasize all of those proactive mental health coping strategies, community cohesion. And also, it's been a time of tremendous policy interest at the federal level. There is more bipartisan support for mental health parity and other really important suicide prevention policies. Next slide. And so I'll go ahead and press through one more. Okay, so what we now know just in terms of suicide rates is that 2020 data is in for 25 countries, including the US, although it's preliminary data. And so far what it shows is that there has not been, generally speaking, a rise in suicide rates for most countries and most regions that are tracking that. Japan is actually one exception, unfortunately, which saw a significant rise during the later part of 2020. So the CDC tells us that from 2019 to 2020, there was a 5.6% decrease in the absolute number of suicides. We don't know rates yet. That will be later, that will come from the CDC. Next slide. So just to wrap up here, there are a number of things that we can take away. Suicide is not an inevitable outcome, even during a period as stressful and difficult as the pandemic has been, and how many of the risk factors have been in terms of increased substance use, increased gun purchases, the social, quote unquote, social distancing, which we really prefer to call physical distancing to emphasize the fact that we can remain socially connected. There have been some silver linings, including the fact that during this time of distress, the dialogue around mental health, coping, and thriving has never been higher. And the people in the lived experience community in suicide prevention, meaning people who live with mental health conditions or suicidal struggles or have survived an attempt, say that this is a time that they've never actually felt as validated and as sort of, in a way, understood by the rest of the mainstream population. So that's a very positive thing. And of course, we know telehealth services, treatment seeking has been at much higher rates. Of course, that has meant also that the gap for accessing mental health services effectively has actually widened just a bit. It went from about 9% at the beginning of the pandemic to 12% the last time I looked, meaning people who are seeking services but not able to connect. And I think I will wrap up there with maybe one more statement. So it is a time that we can make a priority at the national level and the global level on suicide prevention. Of course, it's time to do so. It has been time to do so even pre-pandemic, but certainly now at this time. Thank you.
Thank you so much, Dr. Mutier. I look forward to having everyone as part of the panel at the end, because I think there are lots of questions and things that have been brought up, food for thought. Our next speaker is Dr. Shashank Joshi from Stanford Department of Psychiatry, Division of Child.
Good afternoon, everyone. So I am going to see if I can share my screen with you all and hope that my technology cooperates, but I have sent them over should I end up not being able to do this properly. And while I'm getting this all up and ready, I just want to thank all of you for joining us today, and for Lata and the group at CARE for arranging this very timely conference, and just really honored to be part of this. So I think I am able to share. Can you all see this? A little thumbs up, Rona. Okay. So I'm going to speak about mental health and well-being. Over the past year and a half, I'm coming to you as an academic, but probably way more importantly, as a dad, as a Little League coach, community member, and I have no conflicts of interest related to this talk. So stating the obvious, in spite of the amazing news we've been hearing in the last 24 to 48 hours about new guidelines for how we can unmask as people who are, if you've been fortunate enough to be vaccinated, we're talking about the global reality that still, this has been the hardest 18 months of our generation, or probably several others before us, particularly as it relates to youth education, learning. Almost 1.6 billion children and youth were affected. And what's interesting is the worldwide research, most of which started in China and different provinces to look at how did young people do. It suggested, as you might surmise, that some youth may be experiencing increasing mental health symptoms associated with COVID-19, but not all. There was a paper that came out in a journal called Research on Toddler Adolescent Psychopathology, which I put here in the bottom, by Hassang and colleagues, looking at what were some of the factors that helped to alleviate and buffer some of this distress. Those of you in the Chinese world, the Chinese diaspora, those who are immigrants will recognize this symbol. I decided to use it, and I'm not going to tell you quite what it is yet, but it's a theme here, and Sensei Stephen started us off with that theme around vulnerability and difficulty, crisis, chaos, and what is, if that is the yin, what is the yang? Well, not all distance learning is bad. And some research suggests that many students retain more material learning online, especially if you're on Zoom like we are today. If there is an asynchronous component during the week, say on a Monday or a Wednesday, where the students can really design their own schedule, learn at their own pace, join office hours or not, and then have 4 days where they are learning in a synchronous way or some sort of hybrid way, that can really enhance learning. It also enhances self-efficacy, and that's a really important theme in what's been shown in Hassang's research in their paper that came out last month around self-efficacy. We know that e-learning requires less time overall to learn, especially when you have teachers who are really good with breakout rooms and activities. So I suspect that new technology is going to offer us some creative engagement tools as we go forward. So out of crisis comes opportunity. And I used to call this slide, and Dr. Hu has seen me probably present this many times in our cultural psychiatry seminar. We talk about the culturally informed biopsychosocial model with regard to depression. But I've begun to think a lot about well-being in the last 18 months. Early on, there were a lot of folks in California, including our very own Dr. Nadine Burke-Harris, California's first Surgeon General, who is a pediatrician who has, she's putting it up there, a lot of incredible resources that she's put up on Governor Newsom's website. The 6 stress-busting strategies. This came out very early. Our Congresswoman Jackie Spear, who has held several town halls focusing on well-being. So we hear a lot in the medical world. We talk a lot about genetics and family history with regard to mental health challenges, especially depression, neurotransmitter imbalance, other medical disorders. We highlight the neurotransmitter side when we're in school settings. Why are we teaching about depression, suicide prevention, and mental health in schools? Well, because our children and youth have to be healthy enough to learn. Mental health is part of overall health. And because part of our school's job is to make sure that they can reach and teach all students and have access, give them access to the curriculum, we think about the biological when we're trying to engage some of our more reticent school leaders. I would say here in Northern California, we're pretty fortunate because mostly people really get that the academic, behavioral, and emotional are inextricably linked. With our youth in the past 18 months in particular, maybe now in the last month, this has started to bounce back, but the coping skills they would typically use, the everyday doses of well-being that they might get from sitting next to their friends in class, seeing their crush at lunch, looking forward to an after-school sport or activity, being in theater, being in band, some other kind of activity was really interrupted. And these everyday doses of well-being is really what psychologically buffers all of us, but in particular our youth. We think about the social strengths. Again, being in school is a strength in and of itself, and that's been disrupted. Yes, we've had virtual school and we've had connection, but we've also had a lot of disruption, and many articles are being written now, both in the scientific and the lay press, about how so many of our young people have been literally starving for that connection with their friends in school. And even though they've been able to see them, perhaps, as Dr. Mutier pointed out, physically distanced but socially connected, that's been very hard to do until recently. And then finally, this intersectionality that we're all dealing with, the culture of being able to ask for help in a family. Is there a culture of talking about mental health, of help seeking, of promoting well-being by asking others if we don't know the answers as parents? And it is this interaction that either can lead us from stress to distress and possibly depression, or from stress to resilience and well-being. And that's what we've been studying here in our school mental health program, especially in the Bay Area. So from my dear friend, Gray Zhanggu, who has published this book called Professional Well-Being, that I think many folks in our department have contributed to. You can do anything, but you can't do everything. And this is a lesson not only for our young people, but especially for our parents. We do a lot of talks with teachers, focusing on teacher well-being and teacher self-efficacy in order to build their coping capacity, build their resilience, full battery, to prevent this burnout side. So we have been surrounded by these negative inputs constantly, in particular, faculty in our department and teachers we work with in the community who've been trying to do 3 or 4 jobs at once, being full-time parents at home and being the teacher and being the tech support and trying to be functioning at work. And we are here today to share ideas with one another about how we can cultivate the positive inputs and continue now to grow some of our social and healthy activities. One of my favorites is mentorship. Dr. Hu and I have worked with trainees our entire careers. And if you think about mentorship, not only with regard to what we're all doing here as peers for one another, and our senior mentors, who some of whom have passed on, and we try to invoke them in our everyday interactions, but also our students, allowing our students to be our teachers and really approaching this with, as Sensei Stephen said, a beginner's mind. That helps to keep me on this side of the graphic. And then finally, one of the things we like to do at Stanford is shout out our brothers and sisters at Berkeley. And this is a sticky from this article that Brooke Anderson wrote that I've been highlighting in all my talks on well-being the last 18 months, the 6 daily questions for quarantine, which is a really nice exercise in being present, being in the moment, and trying to take advantage of what kinds of things are in our control. Even as we arise out of the pandemic, I think these questions are going to be really helpful to us. So out of crisis or chaos comes opportunity. And there are a number of resources I'm going to highlight here, not only for teachers, but also for clinicians and educators and for parents. So with that, I will turn it back to Dr. Hu.
Thank you so much. Oh, I have to unmute first. Thank you so much, Dr. Joshi. Looking forward to having you as part of the discussion. The next topic is something that I was fortunate to meet Washington Post reporter Marian Liu before the pandemic, and she was someone who was on top of this trend, I think before almost anyone else was, how the pandemic made everything worse for the Asian American community. Thank you for reporting on this important topic.
Thank you so much. And it's an honor to speak with you all. Among you all, I'm usually the one interviewing experts, not speaking with you all. So it's completely an honor. So like Rona was saying, I have been interviewing about the Asian attacks since last February, interviewing victims, parents, kids, and also doing the coverage after the Atlanta shooting. And I'm sure that many of you have seen the stats that from March of last year to March of this year, there's been over 6,000 incidents of hate. Those are self-reported, so it's likely even larger because culturally, we don't speak out. And also, there's a very high threshold to what counts as a hate crime. Literally spoke to a woman in New York, a Japanese senior who was pushed, and when she did make the police report, the policeman even got the location wrong. So she was not taken very seriously at all. And when I say that hate crimes need to have a high threshold, this means that basically it has to be vocally announced. So basically, when I interviewed this Filipino senior that was on the New York subway and his face was slashed across, nothing was said, so it was counted as assault and not a hate crime. So lately, there's been several studies that say 1 in 3 Asian Americans fear threats, physical violence. This is the Pew study. There was another study by the Center of Study of Hate and Extremism, which found 8 out of 10 Asian Americans say they are discriminated in the US. And you mentioned schools in the previous presentation. As schools reopen, Asian American students are missing from classrooms. They make up the smallest share returning back. So for example, in New York, they might represent 18% of all students, but 12% are going back. So this is nothing new. Racism, discrimination in the Asian community is nothing new, but of course, it's been aggravated by the previous administration with words like Chinese virus and being blamed for the entire pandemic itself. And last year in February, I spoke to a college student, and even then she said she wanted to change her face. She was that ashamed of being Asian, and that was then. And now I was hearing seniors who want to disguise themselves as being Asian and try and wear sunglasses on top of their masks. And even when I was trying to do, AAPI Heritage Month, and I was trying to do a happier story, interviewing chefs on their comfort foods, how food is our pride and our pain, connecting, comforting us. 2 said they didn't feel safe, that these are top chefs, celebrity chefs, and they carried pepper spray and a personal safety alarm. 1 even pleaded with me to buy a safety alarm for myself and my parents. My parents take daily walks. They're in the Bay Area too. And I subsequently bought one for myself and my parents. So when I say like the pandemic has made things worse for Asians, like I said, again, it's not new. It's happened since our community has been immigrated here. You know, since laws like in 1882, the Chinese Exclusion Act, where we couldn't vote, we couldn't testify, and we couldn't become citizens. But in the last year, it's gotten worse. And even with the CDC lifting that ban on masks, if you're vaccinated, there are members in the Asian community who are worried again that if they wear masks because they want to be protected, even if they are vaccinated, if they're going to be targeted because people think they must have the virus. This happened at the beginning of the pandemic as well, when people know it's customary to wear masks in Asia, people were being targeted, Asians were being targeted because they're wearing masks. And not to mention the mental health implications of all this, because like many of the speakers I mentioned before, this is a community that may be more reticent to speak up, not wanting attention or just culturally not, wanting to talk. And on top of that, there is a lower percentage of therapists who are Asian. In the medical, 6% of the national population is Asian, while Asian psychiatrists make up 4% of the field. And then Asian healthcare workers also have reported a higher rise in bigoted incidents. Again, 6% of the nation, but they make up 18% of doctors. So it just really goes down to a heartbreaking trend. Thank you.
Thank you so much. And a lot of the things that you've mentioned that are painful are things that we're trying to do something about. And our next speaker, Dr. Helen Sue, has been the president of the Asian Committee of the American Psychological Association, as well as being lead outreach clinician for counseling and psychological services at Stanford, and has been working on some of these problems, including the relative lack of mental health providers that are of Asian origin. So, Dr. Sue.
Mm-hmm. Good afternoon, everyone. It's great to be here with many familiar faces, actually. And I'll be speaking, yes, in my role at Stanford, what we've seen, so there's a clinician view largely, and also nationally in my roles with the Asian American Psychological Association and my roles with the American Psychological Association, how we've had to respond on the turn of a dime, really, to a double pandemic. Okay. So the overview, pandemic mental health, that was something that literally at our clinic, it felt like we had 1 week to transition to telehealth. So that included all the technology as well as the clinical skills of how do you do telehealth. There were legal issues of an entire profession figuring out laws, insurance, all these things about telehealth. With our young population, like at Stanford, we got a lot of feedback. They liked videos. This is a TikTok generation. They wanted videos and they wanted them short and a lot of them. So there was a whole thing about training clinicians to do psychoeducational videos, therapeutic skills, and this is all very new. And most therapists are not exactly the people who just love being on camera. So this was all a big transition. Most therapists are not grief experts either. I am on the grief team at Stanford, and we have constant grief gatherings. And we talk a lot about how Western culture has a very hard time dealing with grief and loss, unfixable problems, and that we are having that whole other pandemic of loss right now. What does it mean when more than 500,000 people have lost their lives? And what does it mean to be doing your classes on telehealth, but also coming to grief group on telehealth as you've lost a parent or a cousin or someone closer? Social isolation, clearly, the previous speakers have addressed impact on mental health. That was huge, especially for people who may not be living with family. Our international students, for example, were one population we were very worried about. Substance abuse disorders, we saw clearly rise. The alcohol sales nationwide went up during the pandemic, and that was very clearly seen. We also saw a huge jump in eating disorders as people desperately sought some kind of comfort or control through these months that felt very out of control. Okay. And then coping with hate and harassment, that we saw since last February or so that this was going to be a problem, that the data have shown every time the past president said a racial slur, a stereotyping slur, that thousands and thousands of repeats would come out immediately on social media. We created the Stanford Anti-Asian Harassment Info website last spring just to give students a place to even understand a little bit of historical context, because for those who didn't have context, it felt even more out of control and alarming. And it brought a lot of people who maybe previously hadn't been in treatment, seeking treatment, but the needs now exceed the expertise. I've done a lot of teaching in major organizations for therapists about working with community trauma and resilience. Community factors are different than individual traumas. Community healing is different than just individual. And really almost no therapist that I've talked to had ever had specific training or continuing education about serving the needs of the diverse API community. So that's a huge challenge therapeutically as we are trying to respond to people living with ongoing trauma, hypervigilance, living in a time of hate and harassment. Okay, and next slide. Meanwhile, we're trying to do research in the middle of all this. We saw clearly that social determinants of health was literally a life or death issue for many communities. API data, for example, has some great infographics, including how many excess deaths each population has suffered during the pandemic, and that it is clearly markedly different for BIPOC communities, just like the vaccination rates are clearly different. And some communities, for example, Filipino heritage healthcare workers, saw great losses far exceeding other groups that many don't realize. For example, we've had more deaths of Filipino heritage healthcare workers in the US and in the UK than in the Philippines itself. So social determinants really impacting certain communities. Again, why it's so important to disaggregate data so that we can even see who's being impacted, and utilizing alliances. So AAPA, for example, is in a major nationwide research project brought to us in alliance with the Black Psychologist Group, Indigenous Psychology, Latinx Psychologists, funded and promoted by the congressional caucuses of people of color. And language and community access. We have great info and research, and yet it's not reaching many communities because of language access. And finally, just postvention. How are we going to do postvention? Preparation and curation of resources, conferences ongoing. I was in Katrina following the hurricane response, and there was a lot of things were winging it, just like we're winging it now. But after this is over, whenever that is, how do we curate? What did we learn? What are the toolkits that we can share remotely? Systemic response to systemic issues. This isn't possible to do in individual type therapy, what's happening. Just really finding the ways to use this newfound technology to share our resources and do better at postvention, which we've not done well enough for suicide prevention, as well as disaster response, dealing with the grief tsunami that is coming as well. Great, and look forward to dialogue with you all.
Thank you so much, Dr. Sue. I'm so amazed by the wealth of information that people have been able to communicate in a short amount of time. I have to admit, Dr. Palanapan and Dr. Lin can attest to when they first said, we're gonna have mental health, we're gonna cover it in an hour, we're gonna have, 5 speakers, each speak for 5 minutes. I didn't think it could be done, but you all are amazing. And I think I'd like to start off with, because I held you to a very, narrow amount of time, before we get to the questions themselves, and please everyone put questions in the Q&A function so that we can get to them. We have until 2:40 but I want to have a very good discussion and make sure to answer all your questions. So before we get to the questions themselves, if there's something that, as I cut you off at the 5-minute period, if there's anything that that you just wanted to finish up, a point that you didn't get to finish making.
I'll just share something, Dr. Hu. I just really appreciated how these presentations were weaved together. You really are such a wizard of doing this. I've known you my whole professional career, Rona, so I'm not surprised, but I'm still impressed. And I also really want to appreciate what Dr. Mutier was talking about regarding the suicide rates, and that this has been actually a little bit of the silver lining, that the suicide rates have come down. Of course, in our emergency rooms and on our inpatient units, we are as busy as ever. I do think some of the messaging is getting through. I think some of the very important culturally focused messaging that's happening here in Northern California, you see a difference being made. You see more people talking about upstream measures and upstream conversations, talking more about mental health. We're about to launch a big study in a majority Asian high school in Southern Santa Clara County. And we have a lot of newcomer families signing up to talk about family relationships, mental health, and help seeking. I mean, this is in the consent form. It's in 4 different languages, and we have people signing up because part of the outcome is we're going to bring workshops like those that Dr. Hu has pioneered, like Qipao, to these communities. And it's difficult. There's not a roadmap for parenting. You make it up as you go, and you learn who to ask. But learning who to ask and being able to ask is sometimes a really brave step. And I think with the conversations that have been happening, even out of the tragedies and out of the increases in mental health distress, we've seen more people having these conversations throughout the pandemic in some portions of the US. So I just wanted to share that reflection. And again, thank you, Dr. Hu, for putting this panel together.
Gosh, you're very welcome. Thank you all for being able to do it. It's a wonderful panel. And as you said, interwoven questions. I think I want to get to some of the interweaving in a moment, but I also wanted to make sure to answer questions as they come up. An anonymous attendee asked, how do we address post-COVID depression, brain fog, and PTSD-like conditions following COVID-19 infection? So this is an interesting area because there was an article in Lancet Psychiatry that 1/3 of individuals who are diagnosed with COVID-19 will develop a psychiatric or neurological problem within 6 months. So there's the effects from the COVID pandemic, on all of us. There's effects on people who already had psychiatric conditions that, navigating through the pandemic world. And then there's also people who have gotten COVID and then develop psychiatric conditions that maybe hadn't been diagnosed before. And then not to forget something that we haven't come up against, but there's also going to be, as we reintegrate into society, Dr. David Spiegel from Stanford Psychiatry has talked about this whole pandemic as being like a learned phobia, that all sorts of things that we didn't used to have to worry about now, an unmasked person touching something, touching your face, and that, like all phobias, we're probably going to have to very gradually learn to get back to some sort of normal, and that we can't expect to just, that the first time we hug somebody who we haven't hugged in a long time, we might recoil a little bit, or they might recoil, and to give ourselves permission to do this. So the specific question then that our attendee asked about this post-COVID depression, brain fog, and PTSD, who would like to address that?
I saw Christina unmute herself.
Excellent.
I wish I had the answer to that. I mean, I'm thinking about the sort of layered effect of the barriers that were there for people to optimize their mental health that had to do with, our own internal beliefs and barriers, our families' cultural norms, and then health disparities, and even just plain old access to care, which is highly variable. We know that. And then I think about how the virus itself is such an unknown entity. I mean, obviously we've learned a lot more, but not everything we need to know in terms of these neuropsychiatric sequelae of the viral infection itself. And so that's an area that I'm sure will be looked into in terms of, is the depression or are the cognitive changes that come from that direct viral infection, is there a different way to address them, which boils down to understanding its pathophysiology? At the same time, recognizing that there's probably quite a bit of overlap between what you had mentioned, Rona, about the sort of human and psychosocial impacts of what this has meant for all of us, and certainly for individuals who had pre-existing mental health conditions or unknown vulnerabilities to mental health distress. And look, this is a continuum. So all of us in the human race have some vulnerability. So, my last thought, and I'm posing more questions than I am answers really, is that Marian's comments were so critical here. And certainly it's not every individual, it's not every family or community who is necessarily experiencing it directly. But when there's an experience of discrimination or violence or assault, that impacts our mental health. And we know more now about that, and even in terms of suicide risk. And this is a very new and sort of emerging convergence in the science to really understand what are those relationships. But I think, what we do know broadly is that sense of support and feeling connected, feeling heard, seen, and understood is vitally important for all of us. And so I'm very concerned that in the AAPI community, there may be additionally to those hate crimes and experiences and fear, a sense of alienation and a lack of allyship amongst other groups, like we do see happening with Black Lives Matter and some other instances. So, sorry to not answer that question super directly, but I think these are all things that we have to work on together, actually. It's going to take multiple disciplines coming together.
In a way, you're saying that when there's this sort of fight or flight reaction, that we have to flock, and that includes people within our community, but also across communities. Because when it comes to Asian American hate crime specifically, we are 6% of the US population. There are not enough of us we can become othered, we can be invisible if we allow that to happen. And so reaching across to all different communities to be able to help one another and ally with one another, I think will be helpful. Before we get to our next question, I wanted to make sure that Dr. Joshi, I think, had another thought on
I wanted to shout out Brooke Anderson's article at the Greater Good Science Center. I put up the sticky note on my talk. The 6 daily questions for quarantine. What am I grateful for? I'm grateful that we have Dr. Sarah Cody as our leader in this community. She should be the Time Magazine Woman of the Year, not only in my opinion, but many, many talks I've given. Who am I checking in on today? Who am I checking in with? I have 4 people in my life over the age of 90. Now 3 of them are over 95. Calling them once a month means I get to check in with a nonagenarian sensei mentor type once a week. What expectations of normal am I letting go of today as a parent, as an academic, as a clinician? How am I moving my body today? How am I getting outside today? And what beauty am I noticing? Am I letting in? I'm trying to take my bike to work, taking different routes. And somebody highlighted this to me. Brooke Anderson's article was there was a patient of ours who had COVID in their family, and they heard a talk and they went to that, clicked on that article, looked at Dr. Nadine Burke-Harris's 6 stress busting strategies and started, taking some ownership back. Yet they're in brain fog and they're tired and they're having trouble breathing, but they can still walk their dog and they can still get outside. And as Dr. Mutier said, physically distanced, but socially connected. I'm seeing my neighbors more than I've ever seen them, even when we were in lockdown, because we were doing it safely during the hours we could be outside. So I think part of it is, how do you enhance self-efficacy? How do you kind of do the things you can do, even as we are starting to unmask, but still trying to maintain safety? I think it's very difficult to know anyone's individual situation, but that was something that I thought was kind of interesting, that someone saw something that I highlighted, someone wrote, they started doing it and wrote back, hey, I tried it and it works. So sometimes it's just the simple everyday things that can really be helpful, even in the face of something like a post-COVID kind of syndrome.
There's multiple factors that are causing our stresses, and there's also multiple things we can do to make them better, very much so. I think that gets to the next question, which I have some thoughts on this, and I also want to hear other people's. How do you preserve hope and a sense of positivity during such a time when being an Asian American feels unsafe? This gets a lot to what Marion was talking about and some of the statistics that I think are really shocking and dismaying. And yet, how do we stay positive and resilient during this? I would say that the first thing is to recognize that there is a problem, that a lot of traditional Asian culture has kind of taught us to push things away or to be stoic. And so I would actually say that recognizing that there's pain there and that there's fear and difficulty, and to not feel bad for feeling bad. I think, Dr. Joshi, that's something that I borrowed from you. Don't feel bad for feeling bad. It's okay to not be okay. So to start with that, for a lot of these talks, and I've been talking about anti-Asian violence for a lot of people, and at one of them I came upon this idea of that pearls are actually things that every pearl has pain as its center. And if the oyster did not recognize this source of pain, not only would it not make something beautiful like pearls, but also it would be injured. Pearls, if oysters just said, I'm fine, then the sand would continue to cut into its soft underbelly. So I think the first thing is to recognize that there's the pain, and then to flock with other people. And then also to recognize that there's different stages of how you recover from something. So the Elizabeth Kubler-Ross stages of grief, I think, also apply to things like pandemics and discrimination. And probably the most important thing that the National Alliance on Mental Illness taught me was that families and friends can go through the different stages of grief at different times. So you all know there's like denial and actually outcry, denial, bargaining, depression, acceptance, and action. People don't wake up and say to each other, okay, we're doing denial today. Is everybody doing denial, or we're all doing bargaining? And in my work with patients who are seriously ill, there's often one family member who will be furiously Googling everything, and one family member who's sort of like, we've got other kids, we've got our jobs, we don't need to just be, eat, sleep, breathing autism or eat, sleep, breathing schizophrenia. And then they'll look at each other and one will say, he obviously doesn't love our child as much, or the other one will be saying, she's gone off the deep end. I don't know what she thinks she's helping by not talking about anything else. So giving each other permission to be in different stages and to sort of, recognize the pain, but also have permission for yourself and for other people to pick it up and put it down and not feel like, denial is not a good strategy in the long term, but there's probably periods of time where I can go through 2 stages easily in one day, sometimes 3. So allow other people around you to be doing that as well. So those are my thoughts on that. I hope I didn't take up too much time. I wanted to hear some other people's thoughts before we finish.
I can add something too. I think it's important to speak up and speak out for our community, for yourself, for your friends, for your family. There was another depressing study that came out yesterday that said most 42% or so of Americans don't even know an Asian name, which is frustrating. So we're always a foreigner in a lot of people's eyes. We have this forever foreigner status. So I think it's important to remember how we are similar, and that maybe it is food or whatever that is our commonality. Also, I wanted to give myself up as a resource in pushing your story out. I think it's important to make the Asian experience, the Asian story, a normality, that we're American just like everybody else. So I'll put my email in the chat too, so feel free to reach out.
I will say too that I've asked people to think about it in an immediate, middle, and long-term coping right now. First of all, there's no PTSD because we're not post. And for a lot of systemic oppression, such as racism, there's never a post, right? But it's so overwhelming. One thing I've noticed in a lot of AAPI spaces too is many of us don't know our own Asian American history and don't even have the language to articulate the things we're feeling, or we're so conflicted. Like I heard one person say, I was really hurt that my office didn't address Asian hate the way they did address Black Lives Matter, but then I feel guilty for feeling what I feel. And then it's just like this mess, right? And it's like, let's slow down. Maybe the immediate is the grounding skills, the not doom scrolling traumatic videos, the just safety and meditation and physical care. And that's like maybe where just you're at or your family right now. The medium is things like, do you learn about your history, speak up more, advocate, develop the lifestyle habits, seek treatment, right? And the longer term really is about how do you do policy change and the long-term planning. And that, yes, our medical and emotional and political and economic systems will be feeling the impact of all of this for quite a while to come. And so I totally understand the desire of so many people to be like, it's almost over, we're vaccinated, like, let's just get back. And it's like that there's no back when we've lost this many people and had so many impacts. And, as Dr. Joshi said, rethinking a whole systems, right, about education or healthcare and where we need to learn to do better going forward.
Thank you so much. I know that we wanted to leave a brief break before the next one, but it's important for the people who asked questions that some of these answers are in the chat section. It looks like Dr. Sue put some in there, Marion Liu as well. And there's a request to let our sensei have the last word, since you were more
Just
quiet.
because I'm the oldest, that doesn't, we're not in Asia anymore.
You might be able to say something very pithy before we go into the break.
And I'm sure it'll be very profound. So I hope everybody's listening carefully. And the sensei is purely because I'm working with, undergraduates, and I want to, let them know that they have an elder. I'm an elder. And I think that, this generation needs elders so badly. They think they're so smart. They're smarter than us older people. So I said, you're not smarter than me. You might be smarter, but I'm still your elder, and I want you to listen up. And so you don't have to call me sensei. But what I was thinking of the Oliver Sacks film, not the film, but the novel. Awakenings, and how everybody woke up after being asleep for so long, and when they woke up, it was like, oh my God, tremendous light. I can't believe how wonderful life is, the joy and the beauty, and it's the small things in life that you find the real beauty and truth, and this sense of appreciation. But then what happens at the end is they all go back to being asleep. Because life is so damn hard, right? Just being on this earth is so hard, and to not escape from that reality is so difficult that they all return to their previous state. And this has been on my mind a lot. I see this. I describe this sense of great awakenings in my students, But I have the fear that they all will go back to where they were. They said they're not going to, but they've had a lifetime of conditioning that's brought them here. And I think that, that they're all going to be tempted to go back to where they were. And I think that's why we need to provide things that we haven't provided before. And so for years at Stanford, I've tried to introduce a kind of psychoeducation that brings in to a classroom, to accredited courses, elements of support, psychological support, emotional support, to integrate that into the scholastic academic world. I've encountered a lot of opposition to that by the academic world is completely divided into two parts, but the academic and the student services. But I feel we need to be innovative in how we provide support for the students, because they so desperately they're in this vulnerable state and they can go in either direction, but they need some guidance. And I think that, that's what we're here for, to provide that guidance about how they can go forth. And it means also bringing in things like the Office of Religious Studies too, to bringing in, because they do want this spiritual life and they want to know why they're here. And so if we can somehow, bring ourselves together to coordinate about, and I think we can provide some very new, innovative kinds of services for students and for in communities as well.
Thank you. Thank you so much. I believe that there's now a 5-minute break before we have our concluding session with all of the moderators. Thank you again, Dr. Sue, for putting some more links in the chat section. Please, everyone who's part of this, avail yourself to those.
Thank you, Dr. Hu. Sorry to interrupt. This is Leta Palniben. I apologize. There is no break at all. And,
going straight into the summary panel.
I'm going to, and thank you, Dr. Hu, and thank you, panelists. That was so enlightening on mental health. And we really learned a lot, not only what to do for our patients and community, but also for ourselves. So thank you for those insights.